In this new lecture, let's start with pneumonia. So there can be first a classification for pneumonia. It can be anatomically and number two pathologically. So on the basis of anatomy first, okay, on the basis of anatomy, it can be number one lobar or lobular. Number two, it can be bronchopneumonia. And thirdly, it can be interstitial pneumonia. Whereas on the basis of pathology, there are two things: the consolidation of the alveoli, or if the interstitium is involved, then infiltration of the interstitial tissue with the various inflammatory cells, or both components may be there. So one alveoli, that's the parenchyma. Okay, so consolidation of alveoli, and number two, the infiltration of the interstitial tissue with various infiltrates. Now the etiology. So it can be virus, it can be bacterial, certain atypical agents, sometimes fungi, and sometimes agents such as oil, paraffin, nose drops also, right? Aspiration. So the viral etiology is causative in 40% of cases. It's because of viruses. So what are the important viruses? RSV. Okay, so the first name first, RSV, respiratory syncytial. Then other viruses, influenza, parainfluenza, adeno, etc. Then in two-third of the cases, okay, now in two-third of the cases it is bacterial. Now on bacterial, it is divided on the age of the child. What are the divisions? In the first 2 months of age, okay. So first 2 months of life, on the first 2 months of life, then from 2 months till 3 years, then after 3 years, and then finally in adolescence. Okay, so there are four divisions. If the child is very young, means less than 2 months of age, the causative agents are most commonly gram negative, for example, Klebsiella E. coli, and certain gram positive ones such as pneumococci, that is Streptococcus pneumoniae and Staphylococcus. Okay, so gram negative is written first. It's more important, and also some gram positive, for example, strep pneumonia and staph. If it is between 2 months till 3 years, then the chief bacterial agents are again Streptococcus pneumoniae, Staphylococcus, and another third one, Haemophilus influenzae. After 3 years, the common bacterial ones are pneumococci, means Streptococcus pneumoniae, Staphylococci. Okay, so in all the three, you can safely say Streptococcus pneumoniae and staph. Between 2 months till 3 years, you can add Haemophilus influenzae also. Okay, and in the earlier ones, gram negative ones were also very important. Now chlamydia and mycoplasma may cause community acquired pneumonia. Chlamydia and mycoplasma, atypical ones, may cause community acquired pneumonia. And gram negative organisms, whenever gram negative will be there, either the child is very small, means whenever the child is weak, the weak child, because he is very small, okay, that means less than 2 years of age, then he will be a soft target for these gram negative organisms, means early infancy, or if the child is severely malnourished, or if the child is immunocompromised, then gram negative ones, they attack more. Atypical ones like chlamydia mycoplasma, they may be causing community acquired pneumonia. And now coming to other much like specific ones now, which occur in specific cases only. As I told you, these chlamydia and mycoplasma, community acquired pneumonia in adolescents and sometimes children also. Then pneumocystis jirovecii and histoplasmosis, and even this coccidioidomycosis, these all can cause in immunocompromised children. Okay, pneumocystis, histoplasmo, and this coccidio. Whereas some rare causes like ascaris, aspiration of food, oily nasal drops, liquid paraffin, kerosene poisoning, these may also be there. And in one third of the cases, it's idiopathic. Okay, so we have discussed all the aspects of this. Now coming to the clinical features. So you'd think of yourself, what are the clinical features? The clinical features, usually when the child is brought to us, it's a relatively weak child, maybe like risk factors first, right? So first we'll throw some light upon the risk factors. Risk factors means anything that's making you weak: a low birth weight, malnutrition, vitamin A deficiency, lack of breastfeeding, passive smoking, large family size, overcrowding, advanced birth order, young age, and air pollution. Air pollution, even indoor air pollution, is a major risk factor. What do you think about the onset of pneumonia? It's usually insidious in onset, starting with first some mild symptoms like upper respiratory tract infection. In certain cases, it's acute in onset, means starts in a very short amount of time with a high grade fever, tachypnea, dyspnea, and grunting. Okay, so insidious, we can get insidious also, and in few cases it's acute also. Now there is a one, so we talked grunting may be present. Another thing is nasal flaring, that means flaring of the ala nasi. And third thing can be the retractions of the lower chest and intercostal spaces. Apart from that, signs of consolidation may be seen. So there are some very specific things like grunting may be seen, nasal flaring, grunting, and retraction, chest indrawing. Okay, so all these things are seen. The onset can be insidious as well as acute. So all these factors, risk factors we discussed more or less. Onset we discussed, which can be insidious and sometimes even acute. Respiratory rate is increased. Okay, so there is tachypnea and yeah, so rarely pneumonia may present with symptoms of acute abdomen. Rarely pneumonia may present with symptoms of acute abdomen because of the referred pain. Yes, referred pain of the pleura to the referred pain of the pleura in the epigastric area, sometimes in the shoulder also. If it is apical pneumonia, okay, so if there is apical pneumonia, then there will be meningismus and convulsions. In case of apical pneumonia, there will be meningismus and convulsions. In these patients, the CSF fluid is always clear. And then other things like grunting, flaring, retraction, and signs of consolidation. Okay. Now we'll have a look at pneumococcal pneumonia. Okay. So pneumococcal pneumonia, it is caused by obviously Streptococcus pneumoniae, transmitted by droplet, and more common in the winter months. Features which will predispose are crowding and reduced host resistance. The bacteria, they multiply in the alveoli, resulting in inflammatory exudate. Scattered areas of consolidation occur that later coalesce around the bronchi and later become lobular or lobar in distribution. Incubation period is 1 to 3 days. The onset is abrupt, means acute onset or abrupt onset. Headache, fever, high grade fever with chills, cough. The cough is initially dry but may be associated with a thick, rusty sputum. Thick, rusty sputum. The child may develop chest pain that is occasionally referred to the shoulder or abdomen, like we talked, that it may present as an acute abdominal emergency. The respiratory rate is high, that is tachypnea is there. In severe cases, now severe cases, right? Even when we study IMNCI, we study the classification of pneumonia, mild, moderate, severe. So severe cases, all these things, grunting, nasal flaring, chest indrawing, difficulty in feeding, and cyanosis are seen. When you will do the examination, the percussion note will be impaired, means there will be dullness, air entry is diminished, crepitations may be heard, and the bronchial breathing is seen over areas of consolidation. The normal vesicular breathing is replaced by bronchial. Bronchophony and whispering pectorality are specific findings. Then meningismus may be present in apical pneumonia. This all was covered earlier. The diagnosis we make on the basis of history. The diagnosis is made on the basis of history, examination, and then we can go for X-ray findings. Leukocytosis is seen. The sputum is examined for gram staining and culture. Sometimes blood culture is done. The demonstration of polysaccharide antigen in the urine and blood is not specific for pneumonia. Polysaccharide antigen is not specific. How will you do the treatment? Antibiotics, that is penicillin G, 50,000 international units per kg per day, given IV or IM, divided doses for 7 days. Sometimes you can go for IV, cefotaxime or ceftriaxone or co-amoxiclav, which are also equally effective. Now let's see what are the points which were covered in 8th edition and are not in 9th edition. So 9th edition is a little more concise. It takes into account only very important points. Certain points of 8th edition have been deleted and few new things are added. Like we saw in the first page of respiratory, the respiratory physiology, one page was added. Okay. So, okay, droplet, winter. Okay, so quickly it's a revision, second time revision. So droplet, winter, we discussed all this. Overcrowding, decreased resistance, alveoli, exudate, coalesce, lobar or lobular. There is no tissue necrosis. So this is a little different point. There is no tissue necrosis. Okay, because necrotizing pneumonia, it's a little different entity. So there is no necrosis here. The as we know that there are four stages, right? The stage of congestion, red hepatization, gray hepatization, and resolution. So this was also missed in the ninth edition because they are just assuming that since everyone has studied pathology, they remember the four stages. So red hepatization, gray hepatization, and finally resolution. Now clinical features, incubation period we discussed, abrupt onset, all this. Cough is dry, later it can be rusty, sputum may be there. Yes, so pleuritic type of chest pain may be present, which is also referred to the shoulder, abdomen. Severe cases, grunting, chest in drawing, all this. Percussion, crepitations, whispering pectoral echi, and meningismus in apical pneumonia. Fine. Diagnosis, history, X-ray, consolidation findings, blood. So leukocytosis, blood culture, sputum examination, all this is yeah covered. Treatment, antibiotics, empirical, awaiting confirmation. Okay. hmm. Penicillin G, we discussed penicillin G. Here they have mentioned about penicillin V also orally, or penicillin G, as we discussed, 50,000 international units per kg per day. Okay, for 7 days. And other options are also third generation cephalosporins or coamoxiclav. The need for oxygen may be guided by signs of respiratory distress. See, in any respiratory problem, obviously you have to say what humidified oxygen, and in severe cases, if nebulized epinephrine has to be given, right? So here also oxygen they have told. And if there is cyanosis, hypoxemia, rapid breathing, all that, you should give oxygen. Keep checking for the pulse oximetry. And for dehydration, give IV fluid. So oxygen, hydration, all that is a common, you can write in everywhere. Okay. And fever should be managed with paracetamol. Okay. Now coming to staph pneumonia. Should we discuss in this? No. We'll continue with staph pneumonia in the next lecture. Thanks a lot for watching.